Pranav, for the introduction, and I would like to thank AIOC for giving me the opportunity. So, I'll be speaking on OCT, what lies beyond. So, we know optical coherence tomography provides us with an optical biopsy of the ocular tissues, and it relates to or involves the light and optic, and it is based on the principle of low coherence interferometry. So what is low coherence interferometry is basically there is a diode light source which is in the infrared range, and there is a beam splitter which splits the light into reference beam as well as measurement beam. The reference beam, it goes into the goes and hits the reference mirror and it is reflected back. The measurement beam, it goes into the ocular tissues and then it is differentially reflected from the ocular tissues based on their density. And both these reflected beams are then detected by the detector and then analyzed by the OCT software. So at a particular point, we'll have an amplitude scan, that is an A scan, and when the multiple A scans are combined, then we obtain a 2D image of the ocular tissues, that is the B scan. So there are different domains of OCT which are available. Time domain, which was the oldest versions, and now we have the spectral domain and the swept source OCT. So in time domain, basically there is a single detector and there is a reference mirror which moves. Whereas in spectral domain and swept source domain, the mirror is fixed, and in spectral domain there is an array of detectors which detect the reflected light from numerous ocular tissues simultaneously. Therefore, the time to acquire the image reduces and the scanning speed is higher. The axial resolution of spectral domain and swept source domain is higher than time domain. And the range of imaging is also different. In time domain, we can only image between the VR interface to the retinal pigment epithelium, whereas in spectral domain and swept source, we can image from the cortical vitreous to the sclerochoroidal junction. So this is how a time domain, spectral domain, and swept source OCT will look like. In the spectral domain, without the enhanced depth imaging mode, the sclerochoroidal junction will not be visible. Whereas in swept source OCT, we can visualize the sclerochoroidal junction very well. So different protocols that we use for scanning the macular area are the macular cube, radial line scan, and raster line scan. So in a macular cube provides a 3D picture of the macular area, and it can be 6 into 6 mm or 7 into 7 mm or a rectangle of 8 into 6 mm. And radial line scans include 6 to 12, can have 6 to 12 line scans at equidistant angles. And raster line scans can be a single raster line or a 5 raster line or a 21 raster line. So this is how these images look like. And then next we have the optic disc cube, which provides us with the optic nerve head as well as the retinal nerve fiber layer values. So this is how a normal optical coherence tomography image of the retina will look like. And this is spectral domain OCT image. And all the membranes appear hyperreflective on OCT, and all the nuclear layers appear hyporeflective. So starting from the innermost layer, that is the we can have a posterior cortical vitreous visible in certain eyes. Then we have the first retinal layer, that is the internal limiting membrane, that is hyperreflective. Then we have the nerve fiber layer, which is again hyperreflective. Then we have a hyporeflective ganglion cell layer because it is a nuclear layer. Then there is an inner plexiform layer which is hyperreflective. Then inner nuclear layer again hyporeflective. Outer plexiform is hyperreflective. Outer nuclear is hyporeflective. Then we have the outer retinal bands. The three important outer retinal bands that are the external limiting membrane, the ellipsoid zone, and then we have the interdigitation zone. So these constitute the three important part of the outer retinal tissues. And then we have the retinal pigment epithelium Brooks complex, following which we have the choriocapillaries and the choroidal vessels, and then the sclerochoroidal junction. So coming to individual disease pathologies in which OCT is very helpful. So VMA and VMT, it may be difficult to assess on clinical examination, and VMA will have an attachment of the detached posterior cortical vitreous from the perifoveal area, but attachment at the center of the fovea. And there will be no distortion of the retinal layers. However, in VMT, the retinal layers will be distorted because of the pull by the cortical vitreous. Now, ERM we can identify, but certain cellophane ERM may be difficult to pick up on clinical examination. OCT can very well pick up the hyperreflective epiretinal membranes and the effect that these membranes cause on the underlying retina, such as shown in the second image, where there is a distortion of the retina and a neurosensory detachment. Now, it is very important to differentiate between pseudo hole, lamellar macular hole, and full thickness macular hole, which may be difficult to differentiate on clinical examination. So pseudo hole has an epiretinal membrane, a hyperreflective membrane can be seen in the first image, which is causing a centripetal contraction, and a well-shaped deformation of the fovea is there. However, there is no loss of the retinal tissues. In the lamellar macular hole, there is loss of the retinal tissues and the edges are sloping. In a full thickness macular hole, there is a full thickness defect starting from the inner layer to the retinal pigment epithelium. So in macular hole, we know that OCT is of paramount importance in prognosticating both the anatomical prognosis as well as the functional prognosis. So we have different indices: the macular hole indices, the diameter hole indices, and the tractional hole index, and the hole forming factor, which can be computed based on the measurements. Now, OCT can be used to differentiate between subhyaloid and subhyalum bleeds. In subhyaloid hemorrhage, we can easily go ahead and do a YAG hyaloidectomy and drain out the bleed. But in subhyalum bleed, it is very difficult because the level of bleed, the height of bleed is less, and we may injure the underlying retinal tissue. Diabetic macular edema, other than monitoring the diabetic macular edema with treatment, it also helps in characterizing the macular edema, that whether it is predominantly spongy, whether it is predominantly cystoid, or whether there is a component of traction. So the treatment will depend on what type of edema there is. If there is spongy edema, then patient needs a systemic control. If there is cystoid edema, then patient needs anti-VEGF therapy. And if there is a neurosensory detachment, then patient will need intravitreal steroids. And a posterior hyaloidal traction will need a vitrectomy to relieve the traction. There are certain OCT biomarkers of diabetic retinopathy which have prognostic importance. So one is the hyperreflective foci within the retinal tissue. So these are different from the hard exudates which are present in the outer plexiform layer or the inner nuclear layer. The difference is that these do not have a shadow posterior to them. And these are considered precursors to hard exudates, and presence of a numerous hyperreflective foci predicts toward future development of macular edema and macular exudation. Another important biomarker is the disorganization of retinal inner layers. If the inner retinal layers are disorganized as seen in the first photo, we cannot make out the different layers. What different layers are there? The ganglion cell, the inner nuclear, the plexiform. So this means the retinal inner layers are disorganized, and it points to a poor prognosis. It also helps us to determine the extent of the traction or retinal detachment. Sometimes it may not be it may be difficult to determine whether the macula is affected by the TRD or not, because we want to take up the patient for surgery or not. So the tractional detachment extent can be made out on OCT. Other than identification of macular edema and monitoring of the patient with retinal vascular occlusion, there are certain features that occur in macular edema associated with CRPO. There is a differential edema of the inner retinal layers because the inner retinal ischemia is occurring in vascular occlusions. So the inner retinal layers appear hyperreflective, and sometimes the middle limiting membrane may also be seen in such eyes. Again, in BRVO, a differential edema of the inner retinal layer will be there, but again, the differential edema will also be in a particular half of the scan. In a vertical scan, it will be either involving the upper half or the lower half. Next, we have the macular telangiectasia, in which there are characteristic signs may be seen. So there is a loss of the retinal tissue, and in advanced stages, we may have an ileum drape sign, in which only ileum is left and other retinal tissues are lost. In myopic maculopathy and tractional maculopathy, there occurs schisis of the retina, and this occurs due to posterior staphyloma and rigid inner retinal layers. So it is very difficult to pick up such features on clinical examination, and OCT helps us in monitoring and following the patients after surgery. Dome-shaped macula is again an entity which is difficult to pick up on clinical examination. It is important to do an OCT of all the high myopes, particularly the pathological myopes. Drusen appear as deposits which are present beneath the retinal pigment epithelium, and these are homogeneous, and these give an undulating appearance to the retinal pigment epithelium. However, sometimes the drusen can occur on the apical surface of the retinal pigment epithelium, that is between the retinal pigment epithelium and the retina, and these are known as subretinal drusenoid deposits or reticular pseudodrusen. The pigment epithelial detachments can be of four types. It can be serous, where the content is clear, and drusenoid when the content is homogeneous, fibrovascular when the content is heterogeneous, suggesting a CNVM, and a hemorrhagic PD when there is a posterior shadowing because of the heme in the pigment epithelial detachment. Geographic atrophy, in a case of geographic atrophy, will have an atrophy of the outer retinal bands, the external limiting membrane, the ellipsoid zone and interdigitation zone, and the RP, and sometimes outer retinal tubulations can be seen at the border. Choroidal neovascular membrane can be divided into three types and can be characterized on the basis of OCT findings into type 1, type 2, and type 3. Type 1 occurs beneath the RP, type 2 above the RP, and type 3 is intraretinal. So pachychoroid disorder is another entity which has gained importance after the introduction of EDI OCT and swept source OCT, because these can image the choroid very well, and the abnormality which is common to these disorders is attenuation of the choriocapillaries and large pachychoroid vessels, pachy vessels. So the large vessels, they are prominent, and there are prominent large vessels, and these occupy most of the choroid, and the choriocapillaries is attenuated. These disorders include the central serous choroidopathy, pachychoroid neovasculopathy, PCV, and focal choroidal excavation. Coming to the inflammatory disorders in retinitis, OCT can help us determine the posterior vitreous cells. They can be made out on ultra high, in high resolution OCTs, and there will be edema and increased hyperreflectivity of the inner retinal layers. We can also make out whether the underlying choroid is affected or not, whether it is an isolated retinitis case or a retinochoroiditis case. In inflammatory disorders of the choroid, the OCT will pick up a bumpy RP. There may be multiloculated pockets of SRF, and there may be presence of posterior vitreous cells. And in addition to that, disc edema will also be there. So OCT will help us in differentiating certain cases in which we are confusing CSE with the VKH or sympathetic ophthalmia. OCT also helps us to differentiate between certain choroidal tumors, although ultrasonography standard, but choroidal metastasis, hemangiomas, and osteomas can be differentiated based on certain OCT characteristics. The recent other advantages in OCT include the NFAS OCT, which provides us with a C scan. Basically, till now we were talking about a B scan. Now, in a C scan, it provides us a surface image. And the benefit of NFAS OCT is that it helps us in precise localization of the lesions, that how extensive are the lesions, and even the minor lesions may be picked up on NFAS OCT. Another advancement that has been there in OCT is the wide field OCT for peripheral retinal pathologies and intraoperative microscope integrated OCT that helps in macular surface procedures. To summarize, OCT is a fast, non-invasive tool to study the ocular tissues by an optical method. And OCT, it should be interpreted in a systematic fashion, starting from the vitreoretinal interface, then the retina, then the choroid, and the sclerochoroidal junction, only after assessing the scanning protocol, that what protocol has been used, which area has been scanned, and what is the image quality. Then only one should interpret it. Now, OCT scan should be interpreted obviously in correlation with the fundus picture, and isolated OCT image, we cannot make out the diagnosis based on that. And the technological progress in OCT imaging is offering these days newer perspectives for better understanding of retinal disorders. Thank you.
Thank you, Dr. Devesh, for the crisp presentation. Is Dr. Shivani here? Can you unmute yourself? Dr. Shivani is a uvea and retina person from IGIMS. Quick question from Dr. Shivani to Dr. Devesh. Anything you want to add or to ask him?
No, sir, not now. We can ask the question at the end of the session.
Okay.
At the end,
okay. Just a quick addition to what Dr. Devesh has already mentioned is about glaucoma, because in glaucoma, you have the ganglion cell complex, which can be identified, which can be measured by the OCT, and various studies show that it can predict changes almost 6 years before what we can pick up in white to white perimetry. In that way, it is one of the better tools, and we can always have dependence on that. Thank you so much, Dr.